criminal class, except the United States Congress. I really appreciate the chance to be with you this evening. I got up at 5:30 this morning and landed here at 2:30, and Lee picked me up at 3:30, and I think this is the fourth meeting we've had this afternoon, so if my voice gets a little cracky, I hope you'll give me some latitude. What I'm hoping to do this evening is provide you at the very least a general and common understanding of the nature of the healthcare crisis. You may not agree with what I propose as the solution, but hopefully you'll go away here with a better understanding of what we're up against and the necessity that we as a nation come to terms with this. It's very appropriate, I think, that we're here at a campus of higher learning with a lot of young people in the room, because I think your futures are tied up with the ability of our nation to solve this problem. And to understand the threat that the healthcare system poses, and also the opportunity that this issue represents, I think it's useful to view the challenge through the lens of the generations that preceded us, and then through the lens of the generations that will follow us. So let me start with a question. How many people here are between 45 and 63 years old? Let's look around a second. Obviously, we've got a disproportionately young audience here, but everyone who has their hands raised is a member of the baby boom generation. These are people who were born between 1946 and 1964. They are predominantly the children of people who weathered the Great Depression, who fought in the Second World War, and who rebuilt the world in its aftermath. This is the largest generation in America. There are 78 million of us, 30% of the U.S. population. And the generation that preceded us, my parents' generation, they were the folks that Tom Brokaw referred to as the greatest generation. These were the people who did, in fact, these amazing things in the earlier part of the last century. My parents were very typical of that generation. My father was born in 1915 in Cedar Rapids, Iowa. My mom was born in 1917 in Joseph, Oregon. And they met in 1939 in Pullman, Washington, where they were both graduate students at Washington State University. And they got married in November of 1940. The Japanese attack on Pearl Harbor found my parents back in Iowa, where Dad had his first job teaching in graduate school at Iowa State University. He was drafted in August of 1943. He was sent to basic training at Camp Robertson, California. And on April 3rd, 1944, he boarded the USS Robert Sherman, a heavy cruiser in New York Harbor, for the perilous 3-week trip across the North Atlantic to Europe. Just before the ship sailed, a Red Cross volunteer came on board and told him that his first child had been born. My sister Ann, who we wouldn't see for almost 2 years. Dad entered Europe through Normandy, not on D-Day, a few weeks after that, and marched across the face of Europe all the way to Berlin. Now, during the 17 months he served with Patton's army in Europe, my parents wrote to each other almost every day. And I've always thought it was kind of a poignant tribute to their 63-year romance that they kept all those letters. And in 2002, my father edited them into this volume that is called The War Letters, and he gave a copy to me and a copy to each of my two sisters. And this is really a very remarkable document, and it tells the story of two ordinary citizens and new parents and the incredible sacrifices that they made to win the Second World War. And before my father died, a couple of years ago, I used to call him up every year on June 6th, which was the anniversary of D-Day, and I thank him for saving the world. Because that is exactly what that generation did. But not only did they win the Second World War, they built our system of higher education. They created the interstate highway system. They built the transmission grid. They went to the moon. They cured polio. They eradicated smallpox. And they created these amazing social programs of the 21st century, Social Security, in the GI Bill, and of course Medicare and Medicaid. And as a result of those sacrifices and those investments, our generation has enjoyed more promise, more opportunity than any generation in the history of this country. Now, I want to start with that perspective because I think it's worthwhile for us, all of us who raised our hands, to ask ourselves what kind of world we're leaving to our children. What's our legacy going to be? And quite frankly, on our current trajectory, it's not a very pretty one. 14 months from today, January 2011, the first of 78 million baby boomers will become eligible for the Medicare program, creating a projected unfunded entitlement of $70 trillion. Now, for a nation that's become acclimated to big numbers, $700 billion to bail out Wall Street, $730 billion in the stimulus package, billions more to the oil industry. $1 trillion may get lost in the margin. It is a number so staggering that it's impossible to appreciate without a frame of reference. So let me give you one. I call this exercise zeros matter. So when you go home, get out your calculator and do the following calculation. 1 million seconds ago was last week. Okay? 1 billion seconds ago was 1972. Nixon was just leaving the White House. 1 trillion seconds ago was 30,000 BC. We've got a national debt approaching $12 trillion, and it's going to skyrocket as the baby boom generation becomes eligible for Medicare. And we're planning to pay for that by borrowing money from Japan and China and other countries that are still willing to give it to us. Giving huge leverage to some of our major international competitors, threatening the fiscal stability of our government, and leaving this huge burden of debt for our children and grandchildren to pick up. How we address this issue, I think, is the defining question of our time. It is the unfinished business of the baby boom generation. It's our turn to give back and to ensure that we leave our kids and grandkids the same legacy of hope and opportunity that we received from the greatest generation. And it is inexplicably tied to the future of the U.S. healthcare system. Now, to solve the crisis in our healthcare system, 3 things are necessary. First, we need an agreed-upon vision. We need a set of shared policy objectives that capture the desired purpose of the U.S. healthcare system, of why we have a healthcare system in the first place. Secondly, we need an accurate diagnosis of the underlying problem, of why our current system is unable to achieve those objectives. And then third, we need to be able to describe the key design elements of a new system that could, in fact, achieve our objectives. So let's start with this question of objectives. What is the purpose of the U.S. healthcare system? Why do we have a healthcare system? The fact is that the purpose of the healthcare system is not, in fact, to finance and deliver medical care. The purpose of the healthcare system is to produce healthy Americans. In other words, healthcare is a means to an end. It's not an end in itself. It has no intrinsic value outside its relationship to a health outcome, except as an economic commodity. And that fact has got to be somehow embedded in our system objectives. Now, I think Dr. Don Berwick and his team at the Institute for Healthcare Improvement has captured what I think is the rational objective for the U.S. healthcare system in 3 points, which he calls the triple aim. First, we want to improve the health of the population. This is about health, not just delivering medical care, right? Secondly, we have to reduce per capita cost. And third, we want to maintain or improve the patient experience in terms of clinical outcomes and patient satisfaction and patient safety. It's important to recognize that nowhere in the triple aim is the word healthcare mentioned. In other words, healthcare is important only to the extent that it helps advance these 3 policy objectives. The problem is that the debate going on in our nation's capital today has almost nothing to do with a system, creating a system that improves the health of Americans. It's all about paying for the system that we already have. And I think that's a fundamental misdiagnosis of the problem. And to understand that, let me give you an analogy by comparing the performance of our healthcare system to the performance of a car. So bear with me a minute, this will actually make sense. We all know that every car has a maximum speed, okay? So you can take your Porsche or your GMC pickup or your old Honda Civic out to the Bonneville Salt Flats, put the pedal to the floor, and pretty soon that car is going to go as fast as it's going to go, right? It's going to reach its maximum speed. What if you don't like it? What are your options? Well, you can yell at your car, I suppose. You can give it an incentive. You can file an incident report with someone. You can call up Lee and have him introduce a car owner's Bill of Rights to the legislature. But guess what? It's not going to go any faster because the maximum speed is a function of the car. It's built into the car. And by the same token, the inefficiency and poor performance of the U.S. healthcare system is a function of the system. It's built into the system, and that's not going to change just by changing who pays for it. And that becomes obvious when we look at those factors that have the greatest impact on people's lifetime health status. We find that 40% are lifestyle and behavioral. 15% are socioeconomic factors. 30% are genetics, who your parents were, but only 10% has anything to do with involvement in the U.S. healthcare system. In other words, 90% of what affects your lifetime health status has nothing to do with the healthcare system. So, if we want to solve this problem before the cost simply overwhelms us, we have to explain this discrepancy between spending $2.5 trillion a year on medical care and getting only a marginal return on investment in terms of health. There are three basic reasons for that discrepancy. The first one is that our financing system creates huge barriers to access for millions of Americans, forcing them to delay needed care or eventually go to the emergency department, often when they're very, very sick. In fact, the financing structure of the U.S. healthcare system was never built around a broad commitment to access. It was built around something called categorical eligibility. Now, what does that mean? It means that in the United States, to get publicly subsidized medical care, as opposed to publicly subsidized education or public safety services, you have to fit into a category. And these categories were created through three unrelated acts of Congress in the middle of the last century. The first one was called the Tax Reform Act of 1954. That was the point at which Congress told employers they can deduct from their taxable income the cost of their contribution to their employees' health care. That's also not counted as a taxable income to the employee, so it's a publicly subsidized tax benefit for everyone with employer-sponsored coverage. It costs us probably $250 billion a year today. So that was the first act. The next two, totally unrelated to the first one, was the enactment of Medicare and Medicaid in the middle of the 1960s. Now, those three acts then form the underlying financing structure of the U.S. medical system, which has a public arm and a private arm. On the public side, you have Medicare and Medicaid, and on the private side, you have mostly employment-sponsored health insurance coverage. But because the system is built around these categories, not a broad commitment to access, there's a gap between the public and private arms of the system. And in that gap are people that don't fit into a category. So think about it. You're not 65, so you're not eligible for Medicare. You don't meet the income or categorical requirements for the Medicaid program. You don't work for someone who offers workplace-based coverage, but you can't afford an individual policy in the private commercial insurance market. That's where the 50 million Americans are. Now, because we've built this system on categories, not on a commitment to access, the United States stands proudly alone among industrialized nations in never answering the most basic question in the healthcare debate. And what's that question? The question is, in the United States of America, who has the responsibility to pay for the healthcare needs of the growing number of Americans who can't afford to do so themselves? And because we never answered that question as a matter of explicit public policy, by default we let the economic market answer the question for us. But markets are designed to make a profit, not necessarily to foster social responsibility, so it shouldn't come as a great surprise to people. No one goes out and competes for people who won't pay them. Right? In fact, in our market-oriented terminology, people who have health insurance coverage, we view them as market share, and we want their business. And people who can't afford to pay are called liabilities. And we've devised a variety of sort of implicit ways to avoid seeing them, and the most insidious is one called cost shifting. So what happens is when these people in this gap get sick enough, they go to the emergency room. And in the emergency room, federal laws require that we see and treat them, and then the uncompensated costs are shifted back to these public and private payers through incremental increases in your insurance premiums or your bills. So one of the reasons your insurance keeps going up is you're picking up this cost shift from people who can't afford to pay for it themselves. Then what happens is these public and private payers simply shift the costs back onto individuals. So the state does it by changing the income eligibility requirements in the Medicaid program to reduce the number of people that the state has to cover. I call that redefining the poor for accounting purposes. Yesterday you were poor and you are on Medicaid. Today we've decided you're no longer poor. We balance our budget. You get to go out into the coverage gap. The private sector does the same thing. They either drop coverage altogether, and it's important to note that there's about a 5% annual erosion rate in private sector employer-sponsored coverage because of cost, gradually going away, because it's just simply no longer affordable, particularly for small employers. Or they increase co-payments and deductibles, which increase out-of-pocket expenses to employees who at some point can't afford the cost of health care. They go back into the emergency room, and the cycle repeats itself. Now, there are those who will say that we can't afford universal access. I argue that we can't afford not to have universal access, because we have a policy of universal access in America. It's called the emergency room. And under that policy, we refuse to pay pennies to manage your blood pressure in the community, but we're happy to pay tens of thousands of dollars to treat your stroke once you've had it and come into the emergency room. It's a policy that says we won't pay pennies to ensure that all of our women have access to good prenatal care, but we're happy to pay the cost of resuscitating a 500-gram infant in the neonatal intensive care unit and then shifting that cost to the shrinking employer base that's still willing to pick it up. This policy makes no sense in terms of a business plan, a social policy, or anything else. So the most fundamental question that we have to answer on the financing side of the debate is this one. In America, who has this responsibility to finance the care needs of the growing number of people who can't afford to do so themselves? Because we've never answered that, that's the first reason why we have such a huge expenditure on medical care and such a marginal return on health. The second reason has to do with the fact that most of the cost in the healthcare system today comes from treating people with one or more chronic illnesses. Diabetes, excuse me, I knew this was going to happen. Excuse me just a second. You have, I should be doing more listening. Little Oregon Pinot, please. Excuse me, most of the cost in the system today comes from treating people with chronic illnesses, and that will go up as the population ages and more people develop these chronic illnesses. Now, secondly, the way these dollars are expended across the population is very uneven. 1% of the population spends about 35% of the healthcare dollars in any given year. 10% of the population spends about 70%. Which brings to mind the infamous 20th century bank robber Willie Sutton, who, when asked why he robbed banks, infamously replied, because that's where the money is. So if we want to fix the healthcare system, it might be worthwhile looking at this 10% of the population that's driving most of the cost. And most of that cost is treating the acute complications of people with chronic illnesses. Now, we know a lot about chronic disease. First of all, we know that most chronic illnesses can be prevented, or their onset can be dramatically delayed through lifestyle and behavioral choices. Secondly, we know that these diseases are gradually progressive, and we know how to manage them in order to avoid the acute complications that cost so much and drive people into the hospital. But it requires a certain type of medical practice model, a certain type of delivery system. First, it requires a team of doctors, nurses, and lay people who work together off a shared plan with good communication of information. Secondly, it requires that we recognize the individual is the most important caregiver in chronic illness. So you may have congestive heart failure. As a physician, I can give you some medication for it. If you don't take that medication, if you don't stop smoking, if you don't exercise, you're not going to get better. So we need to recognize that the individual is the most important caregiver, and not everyone has the same capacity for self-care. That has to be reflected in the treatment plan. Third, we need well-educated patients who can recognize the sign of a complication. So if you have congestive heart failure, you should be weighing yourself every day. If you wake up one morning and you're 2 pounds heavier than you were yesterday, you need to know that means you're having a problem, and you need a system that you can navigate, that you can reach the right person immediately so they can help you stabilize yourself without having to come into the hospital. Okay? This is old knowledge. We know how to do this. There's places around the country that do it very well. The problem is that the delivery system we have today was designed in a completely different way than the demands that are being placed on the system. First of all, our system is built around what I call an acute care infectious disease model. Episodic medical interventions of high intensity, treating a stroke or a broken bone or a heart attack. That makes sense for certain things, certain life-threatening emergencies. It also makes sense for some non-life-threatening emergencies like a sore throat. The problem is it doesn't make any sense for managing chronic conditions, which is where most of the cost in the healthcare system is today. Secondly, most doctors still practice by themselves or in small groups. Only 4% of doctors in this country are in group practices of more than 50. When we were in medical school, we didn't learn how to spell teamwork. We learned how to spell autonomy and do it alone and sovereignty. The problem is that most doctors today still operate as isolated economic entities without a lot of formal communication or collaboration with one another. And that is a huge problem because the person with one chronic illness on average has 5 to 7 physicians taking care of them. If they don't talk to each other, the potential for drug interactions and gaps in care and other complications is simply enormous. And finally, we don't have very good information. If you go to your physician's office, in most cases around the country, medical information is still recorded on paper records locked up in doctors' offices and hospitals. And even if you have an electronic medical record in your office, it may not be interoperable with the 5 or 6 other people who are taking care of the same patient. So these structural problems are the reason that most people with chronic illnesses, diabetes or congestive heart failure, get into the healthcare system only when they're in a crisis and get the appropriate care only about 50% of the time. For example, the most frequent reason people on Medicare go into the hospital is for congestive heart failure. Nationally, 40% of those people are readmitted within 90 days with congestive heart failure. That's not a financing problem. It's the fact that we don't have a system to take care of people after they leave the hospital to make sure they don't come back in. And that's partly due to a set of perverse financial incentives that basically encourage acute care interventions and discourage reorganization around wellness and prevention. So, for example, today there are 9,000 different billing codes to which doctors and hospitals get paid, but there's no billing code for a cure. Hello? There's no billing code for prevention. There's no billing code for health improvement. They're not billable events. So most of the money in the system is being spent on the acute complications of people with chronic illnesses at the expense of organization around wellness and prevention that we really need to solve this problem. So that's the second reason that we're spending so much and getting so little. The third reason has to do with this 40% of health status that's determined by lifestyle and behavioral choices. From that, it would be easy to conclude, as many people do, that if individuals just made better choices, if they assume more individual responsibility, we would reduce morbidity and mortality and demand on the healthcare system. And while that's undoubtedly true, the ability of people to make those choices is profoundly affected by a complex set of socioeconomic factors. So for many people, those choices aren't really choices at all. We know, for example, that income level affects health status. People at the bottom of the income ladder are twice as likely to die prematurely or have a serious illness as people at the top. We also know that there's a set of easily identifiable social and medical risk factors to which kids are exposed in the early years of their lives. It involves things like poverty, teen pregnancy, substance abuse, involvement with the criminal justice system. And if untreated, those risk factors have an almost linear correlation with school failure, school dropout, social dependency, and involvement in the criminal justice system. We also know that the lifestyle and behavioral choices that lead to childhood obesity and type 2 diabetes are also locked in very early in life. But because treating those risk factors aren't viewed as part of the medical system, they're traditionally uncoordinated and unfunded, and the first things that are cut during an economic downturn. My point is that a strategy for sustained early childhood investment on wellness and prevention has got to be a foundational component of any system that hopes to achieve the triple aim. And that's not even really part of the national health care debate today. So my point is that to create a system that can achieve the triple aim is going to require transformational reform. You can't get there by nibbling around the edges of a profoundly dysfunctional system put together in the middle of the last century. So let me take a moment and try to describe to you the key elements that would be necessary for a system to achieve the triple aim, to improve the health of the population at a lower cost without sacrificing quality. The first thing is we have to develop a much more rational financing system by explicitly confronting our lack of a universal policy of universal coverage. We have to answer the question, who has the responsibility to pay for the health care needs of those who can't afford to do so? And I believe at the end of the day, this is going to be a public sector responsibility. Just as it's the public sector's responsibility to ensure that kids have access to primary and secondary education, just as it's the public sector's responsibility to maintain the national defense and provide fire and police protection, I think it's a public sector responsibility to ensure that everyone has access to some level of health care that can maintain their health. But, and this is very important, because of the reality of fiscal limits, because public resources are ultimately finite, it can't be an open-ended responsibility, which means that universal access is, by definition, access to a defined benefit. And that defined benefit, it seems to me, needs to be developed through a transparent public process in which we prioritize medical services from the most important to the least important based on the health effect of the entire population, very similar to what we've tried to do in Oregon under the Oregon Health Plan. Secondly, this floor, this basic level of care to which we're all going to have access, has got to include what I call value-based cost sharing. Excuse me. In which co-payments and deductibles aren't simply used to shift cost to individuals, which is the case today, but rather to try to create incentives for individuals to purchase high-value care. So, for example, there might be no co-pay or deductible for services that are very, very effective or rank high in terms of their effect on population health, and higher co-payments for more elective and discretionary services are things that rank lower. So let me give you an example. There might be no co-payment no deductible, no individual cost sharing for screening services for breast cancer, prostate cancer, hypertension, diabetes, well child care, immunizations, or the medications you need to treat these chronic illnesses. Because creating any kind of financial barrier to access those services creates huge economic and human costs downstream. But if you have a service for which there's less medical evidence to support its effectiveness, like surgery for low back pain, maybe there's a 50% copay. Or if you and your spouse want to determine the sex of your unborn child with an ultrasound, when the ultrasound isn't indicated for a normal term pregnancy, you can get that too, but you have to pay the whole thing out of your own pocket. So the point is that value-based cost sharing recognizes two important things. First is that people with more money can always buy more stuff, including medical care. And secondly, we are always and inevitably going to have at least two tiers of health care in this country based on income. But, this is very important, there shouldn't be a qualitative difference between those tiers in terms of clinical outcomes. Finally, the revenue, not all the revenue in the system, but the revenue that's essentially funding this portable floor for people, needs to flow to local and regionally organized risk-bearing entities, each of which assumes responsibility for the health of a defined population. Now, that delivery entity could be a hospital with an affiliated physician group, could be a large primary care group practice, it could be an entirely new entity. But organizing care around a defined population, to me, is the single most important element of a new system. That allows the medical system to develop partnerships with other community entities to allow prevention and wellness and the clinical care to be integrated into a true health system. And the value of that can be seen right here. Organizing care around the defined population gives everybody in that population a single point of contact with the care system. It allows them to negotiate the care system, to know who they need to contact when they weigh that extra 2 pounds and they have congestive heart failure. Gives them an individual case manager or advocate in the system. It allows you to do a population-wide health education program and to identify individuals who are having particular difficulty making those healthy choices. It allows you to identify the at-risk children and families and to invest in them to make sure kids get started on a healthy life trajectory. It allows you to do regular ongoing screening so you can pick up early signs of diabetes or congestive heart failure early and get that individual in the treatment plan. So in short, it allows you to effectively manage that 10% of the population that's driving 70% of your cost. Now, if you tried to do that here in Illinois, in Elmhurst, you would suddenly realize that we have to have much more flexibility in the way we spend Medicare and Medicaid dollars to create a system like that than we do today. And let me give you an example. Let's supposing somewhere in Elmhurst you have a frail 92-year-old woman with well-managed congestive heart failure who's living by herself in an unair-conditioned apartment. Okay? And let's say you have a heat wave. Let's say it goes up to 105 degrees for 3 or 4 days. That increase in temperature in her apartment is enough to tip her over into full-blown congestive heart failure. Under the current program, you won't know about that woman until she shows up in your emergency room. Under the new system, someone would be checking on her on a daily basis to make sure she's taking her medication, to make sure she hasn't fallen, to make sure she's doing okay. Doesn't have to be a doctor. Doesn't even have to be a nurse, a new health worker whose job it is to help make sure that person is complying with their treatment plan. Under the old system, under the current system that is, Medicare will pay for the ambulance to bring her into your hospital and the $50,000 to treat her congestive heart failure. Under the new system, we can buy her a $500 window air conditioner, which is really all she needs to stay healthy in her apartment and out of the healthcare system. So it gives us the ability to, within that defined population, spend money to produce health and keep people healthy, rather than simply wait inside our hospitals and offices until people get sick and then deal with the acute medical complications. Now, obviously, what I've described to you is a system that doesn't remotely resemble the one we have today. And moving from our current system to that kind of system poses a huge political obstacle because of the huge number, I'll hop over that page, because the huge number of economic stakeholders that are invested in the status quo. And you know, during this current national health care debate, we like to view stakeholders as sort of just the big insurance industry, drug industry. The fact is we are all part of one stakeholder group or another. People who aren't insured are part of a stakeholder group. People who are on Medicare are part of a stakeholder group. Employers are part of a stakeholder group. Doctors, hospitals, medical device companies, etc. And here's what happens. Whenever somebody basically proposes a new system, all of those stakeholders do a little bit of mental calculus. They go, let's see, given the current incentives and where I've got my money invested today, if I go to that new system, I'm going to take an economic hit somewhere along the way. And all of those stakeholder groups, whether they're consumers or providers or insurers, have the ability to jam things up in the political process. And you've just been watching that happen in Washington, D.C. for the last 8 months. So individually and collectively, we have prevented a serious discussion of the underlying of solutions to a problem that's threatening the fiscal integrity of our country out of fear that we'll lose something economically in the short term. And to give you an analogy of sort of where we are today in our country, imagine that under this bridge there's a raft. And we'll call that raft the U.S. healthcare system. And in that raft are all the various stakeholders that you've been watching fight with each other in Washington, D.C. There's a doctor in there with his or her stakeholder paddle. Right? There's a hospital CEO, an insurance company executive, someone from Big Pharma's in there. There's a nurse who is represented by SEIU. There's someone on Medicare. The AARP's in there. They're all in there. We're all in this raft. And we're floating down the river, and suddenly we come around this bend here, and the river disappears. And we can hear this ominous rumbling and see this mist rising from where the river used to be. So what do? Now that the danger is clearly in front of us? I would argue it's about 14 months away to live. Well, we turn around with our backs to the danger, and we grab our stakeholder paddles even tighter till our knuckles are white, and we start working like crazy, trying to keep our end of the raft upstream, deriving some perverse sense of security from the knowledge that the people on the other end are going to go over before we do. That's exactly what we see playing out. We can do better. In fact, we have to do better because what really is at stake here is the fiscal integrity of our country. Anyone who believes that China is going to loan us $70 trillion to fund Medicare is living in a different reality. So the practical political challenge we face is represented here. If this is economic burden on this axis, and this is time, and the current state is our current medical system, the one we know and love and seem to be clinging to, and the future state is a system that at least has those parameters I described to you, okay? If we could move from where we are now to the new system and the economic burden and everybody went down during the transition, the politics would be easy. Everyone would win. We would have done it a long time ago. The fact is it looks like that. There's no question but that given the incentives and the trapped equity in the current system, going from here to here, individuals and institutions are going to take a big economic hit. And all of them, as I said, are able to jam up the political process, keeping us clinging to this raft even as we get sucked towards the edge of the precipice. So to put together the politics of reform, we somehow have to shift the debate upstream from where we want to end up to how we get there. We need to make the politics and economics of this transition explicit. Don't pretend they don't exist. Don't pretend there isn't a lot of trapped equity, that there aren't a lot of perverse incentives in the current system. Let's get them on the table and shift the debate from how an individual stakeholder is adversely affected to how we can mitigate the impact on everyone as we move to a more rational and sustainable system. Now, whether or not you agree with the bailout or the propping up of the auto industry, that is a pretty good illustration of what I'm talking about here. The loans to the auto industry weren't made to allow them to continue to produce big cars that couldn't compete on the world market. The idea was to help them restructure their business plan to produce cars that could compete to gradually increase employment and stabilize the industry. I think that if we're going to spend more money on healthcare, it's not about expanding access to a system that's utterly dysfunctional. It's putting money right here to try to create the incentives and change the business incentives to move us from the current system to a much more rational. But if we don't have agreement on where we want to end up, there's no political pathway by which to get there. As the Roman Senator Seneca once said, no wind is the right wind if you don't know what point you're sailing for. So until we can agree on where we want to end up, it's going to be very, very difficult to do this. So our challenge today, it seems to me, is to build consensus around what the new system would look like if, in fact, we want to improve health and reduce cost and maintain the quality of care. Our challenge is to agree on that vision of the future and then to shift the debate from where we want to end up to how we're going to get there. You know, when John Kennedy announced in 1962 that we were going to go to the moon, he had just been given a report from the National Science Council that told him it was impossible to go to the moon. We didn't have the technology, we didn't have the capacity, we didn't know how to do it. We couldn't do it. He gave the speech anyway. What he gave us was not a roadmap, but a destination. A vision, a common purpose that allowed us to muster the innovation and creativity of this nation to get there. That's what we need for the healthcare debate. We have to shift that debate, and it has to start here. Now, the obstacles that we're going to face in trying to make the transition to a more economically sustainable and effective healthcare system may not be as obvious as the menace of the Third Reich that our parents and grandparents had to face. But the obstacles are just as deadly sure, partly because they're less obvious. They're not as obvious and dramatic as a Pearl Harbor. They're not as obvious as the specter of a Nazi panzer division, snuffing out the flame of freedom as it rolls across the face of Europe. But I can promise you this, those obstacles, if we are able to collectively overcome them, will have just as much impact on the lives of our children and grandchildren as did the winning of the Second World War of my generation. Albert Einstein once said, you can't solve today's problems by using the level of thinking you were at when you created them. It's pretty much where we are today. But I prefer the way the late Western novelist Edward Abbey put it. More succinctly, but probably less eloquently, when he said, society is like a stew. If you don't stir it up from time to time, you get a lot of scum at the top. Our job is to stir it up. Our job is to accept the fact that the responsibility to reform the healthcare system doesn't actually belong to somebody else. It doesn't belong to the administration. It doesn't belong to Congress. It doesn't belong to the state legislatures. It belongs to us, right here in Elmhurst and in communities around this state and around this country. It's something we can do. And I think it's something we have to do. And if we're not willing to do it for ourselves, we should do it for our kids and our grandkids, who on our current trajectory are inheriting this staggering burden of debt and this dysfunctional system that we built on our watch and through our inability to act in the public interest are allowing to be perpetuated. Let me close with the words of Oregon poet Kim Stafford, who, much more eloquently than I, captures, I think, the challenge and the opportunity, but also the responsibility embedded in successfully making this transition in what he calls Lloyd's story. It's a true story. Lloyd Reynolds, the international citizen of Portland, spent his last days silent, unable to write or to speak, lying in a hospital bed. On his last day at home, as his wife scurried to pack his suitcase for the hospital, Lloyd made his way outside of the garden, and there she found him on his knees, awkwardly planting flower bowls with a spoon. Lloyd, she said, you'll never see those flowers bloom. He smiled at her. They're not for me, he said. They're for you. Salmon coming home, they're for you. Calls to the wild geese, they're for you. The last old trees, they're for you and your children to the 7th generation. They're all blooming and being for you. That's our challenge. To plant the seeds of tomorrow. To put that flag, that stake, that description of the new system that we want to move to in the next 5 or 10 years, and then personally commit ourselves to that quest by acting and by leading, not by victims of the past, and not as captives of the status quo, but as proud, confident architects of a new and better future. Thank you.
Well, I think we now know why Governor Kitzhaber served 2 terms as governor and is the favorite candidate for re-election as governor, and we wish you well. Now it's the time for you to respond and for questions to ask for a noted leader in healthcare reform and to be part of this discussion. This is your community, your college, and we ask you to participate. Heather has, or who has the, oh, you're going to take this one? So you're not going to allow me to speak anymore? Okay, here you go. Over here is Bob Robertson, and back there. Raise your hand high so Chris is coming around. We will get to all of you, I promise. As long as your voice is up.
It's easy for you to say.
John,
Yes,
my name's Milt Honnell. I'm 81 years old, and I couldn't take notes fast enough. Is what you spoke about tonight, is it printed someplace?
Yeah, it's I can actually get a copy to the hospital, but it's on the Archimedes website. It's really easy to remember. WeCanDoBetter.org.
WeCanDoBetter.org.
Yeah.
Okay.
But also give a copy of the PowerPoint and the speech electronically to the hospital.
Thank you so much.
Excuse me, the college. Absolutely. What am I saying?
I had a question based on what you closed with. The idea that the person who is planting the flowers is not going to get to see them bloom. How does the age of a person seeking treatment factor into your model for sharing costs of treatment?
The question was, how does the age of a person factor into the model? And I would say that it doesn't. I think the question is the effectiveness of the intervention. It's not the person's age. And I think if the objective is to produce health, then we need to make sure that the medical care we provide is actually effective in producing a positive health outcome. So I don't think I'm certainly not talking about age-based rationing in any way, shape, or form. I think there's a lot of stuff. If we define a benefit as something that actually is attached to a positive health outcome, there's a lot of the healthcare system we can get rid of today without adversely affecting people's health, regardless of what age they're in.
Can you tell me what the results have been in the state of Oregon with your program? How long have you had it in effect, and has there been an improvement in the health of the people and the reduction of costs and the experiences?
Yeah, the Oregon Health Plan, I'll take like 1 minute and kind of give you a little summary because it was a bit complicated. We created this back in 1989. And the impetus for it was that when states, Medicaid, as you know, is the state program that finances health care for people in poverty. And it's a federal program that's run by the states. So the feds have real control over how states run the program. When states face a revenue shortfall, when they don't have enough money, what they traditionally do is either cut what they pay to doctors and hospitals, which often results in doctors and hospitals not seeing these people, or they change the rules to reduce the number of people who are covered. They change the income eligibility requirements to reduce the number of people who are covered. I call that redefining the poor for accounting purposes. So we'll say, oh, yesterday you were poor, you're covered by Medicaid. Today we decided you're no longer poor, we don't have to pay for you, we've saved some money. So Oregon said, we don't want to do that anymore. We want to define who we think is poor. We defined it as anyone under the federal poverty level. And then we passed a law that says we can't throw those people off anymore. We're going to make a list of services, and if we have to cut something, we're going to cut the services at the bottom that are least effective in producing health. So that was what the plan was, and we implemented it in 1994. Initially, there was a significant reduction in ER visits and uncompensated care because people actually had a way to come in and get seen short of going into the emergency room. We had a significant reduction in low birth weight infants because women were getting access to prenatal care in the first trimester. And since 1994, almost 2 million individual Oregonians have benefited from the plan. Having said that, the costs continue to go up because Medicaid can't be isolated from the larger healthcare system. So now the Oregon Health Plan is still in place. We're still using the priority list, but the legislature's gone back to the old practice of throwing people off the program. So it was, I think, a success in the sense that we were able to demonstrate that you can create a rational priority list. It's done transparently and people perceive it to be fair. You can actually do that politically and clinically, but you can't solve the healthcare crisis just by playing around with the Medicaid program. So Oregon is still facing pretty much the same challenges in healthcare that the rest of the country is, notwithstanding the Medicaid experiment.
Governor Kitzhaber, I agree with you about the prevention aspect of healthcare, how we need to do more of it. I think President Bush's Medicare Part D prescription drug plan, sort of, in a way, kind of is doing that by making sure seniors have enough money to pay for their drugs. It keeps them out of the hospital, to somewhat. I've seen it with my grandfather. But in terms of Medicare, if Medicare is a government-run program, and if it created $60 trillion in actuarial gap, won't the additional 50 million uninsured added to a government type of system, won't that swamp or create more of a bigger actuarial gap than the benefits of prevention? What's your view on that?
Well, I think adding 50 million Americans, whether they're to a public program or through the private commercial insurance industry, will swamp the system. My point was here that just giving more people a way to pay for health care doesn't solve the underlying cost drivers, which is really the way health care is organized and delivered, and the fact that we're focused on medical care, not on producing health. So I think that the debate over the public option, for example, was a distraction. It was an ideological debate, not about whether everyone should be able to afford to pay for health care, but what role government should have versus the private sector. which is an interesting debate, but it misses the larger question about a system that's focused all on delivering medical care after the fact and almost no focus or investment on front-end health, wellness, and prevention. So I think you've got to, A, reorganize how healthcare is organized and delivered. We can fight about the appropriate role of government and the private sector. We're always going to do that. There's nothing wrong with that. But what you're paying for, whether you pay for it through Blue Cross or Medicare, has to be a fundamentally different animal than it is today in order to solve the problem. And we've got to provide at least as much attention on keeping people out of the healthcare system as we do taking care of them after they're sick and get back in, and get into it.
Governor, well, there are a lot of people that feel that, Governor, a lot of people think that the price of malpractice insurance that doctors have to pay is one of the factors that makes medical care so expensive today. Your view to the future, is there any components or plans to rein in those kinds of settlements that people, I guess, you read about them and everyone thinks they're exorbitant and their insurance is exorbitant?
Yeah, the question had to do with medical malpractice reform, tort reform, and sort of the implications of that as part of a solution. Let me say, first of all, that medical liability is an issue, but medical malpractice is not a big cost driver in the $2.5 trillion healthcare budget. It's a fairly small item. Having said that, it is a huge problem, particularly in terms of access to certain types of care. There are places in rural America where you cannot get primary obstetrics care because of the medical malpractice premiums. It's exorbitant for other high-risk specialties like neurosurgery, for example. So I'm not saying it isn't a real problem, but I think we need to put it in perspective in terms of the overall. You can fix that and you won't solve the larger problem. The problem with medical malpractice reform is there's two legitimate social values, I think, that are coming into collision. One is access to justice, making sure people do have access to justice under the law, which I think is very, very important in this country. The other is the fact that if we're going to have to limit the amount of money we spend on health care, you're going to have some ability, some liability protection in order to do that. And right now, the way the debate is generally cast, at least in my experience, is a fight between victims and trial lawyers against greedy doctors and big, lavish hospitals. That's a non-starter. I mean, you can tell who's going to win that one every time. So it seems to me that what you have to do is, if you can describe what the optimal system looks like, if you recognize that there are going to be some fiscal limits in that system, you've got to be able to demonstrate that unless you do something about medical malpractice reform, you can't achieve this larger social objective of ensuring everyone has access to care. So you put it into a larger context, and I think the political alliances and the political context changes, and the politics become a bit more manageable.
When you talked about the problem of social justice, two things come to mind, and I'd like you to address how we can change this paradigm of thought that our culture has. Number one, you mentioned the 500-gram infants that get resuscitated. The idea that Americans think that no matter what, that we have to invest every penny in keeping people viable at whatever cost and whatever outcomes they would have. And number two, a lot of people don't believe that people who aren't citizens should be part of this whole picture. How would you address that?
Well, there are two, I think, sort of dramatically different questions. The first one is that the fact is that death is a part of life. Sorry to tell you this, but life is a chronic condition, and none of us are going to get out alive. The fact is that a lot of medical care, particularly at the end of life, is field care that doesn't produce a health outcome or certainly doesn't produce health. And if you allow me, let me spend a minute on that one, because I think this is a very important issue. And I told this story a little earlier today, so for those who heard it, I apologize. But I've had some personal experience with this, and let me try to put this into perspective. I lost my mom in 2007. She was 88, and both she and my father wanted to die at home. And if you poll elderly people or the AARP or the Great Panthers, there's a big emphasis on durable powers of attorney and advance directive. Most people don't want to die in an acute care hospital, but a whole lot of people end up there. As she began to fail, she developed a lot of muscle pain, and we took her to see her doctor, and the workup revealed that she might have an undiagnosed cancer. the workup for that would have been very, very invasive, and she didn't want it done. She was tired, she just didn't want it done. So the doctor said, well, we'll just check your blood work every couple of weeks and see how you do. And I was with her, and I said, well, why would you want to do that? There's this kind of uncomfortable silence, and I said, you know, if you keep checking the blood work on an 88-year-old person, you're going to continue to find abnormalities. And if you're not going to run them all down, why do them? My friend Stu Altman likes to say there's no such thing as a healthy American, just someone who hasn't had enough tests yet. So she went home, and the first thing I noticed was this dramatic change in the quality of her life, because she and my dad had been focusing on the laboratory. What's the blood count? What's their coumadin level? What does this mean for, you know, the drugs we're on? Driving up and down to the lab, and they probably shouldn't even have been driving at their age. And they shifted their focus. They let go of what they couldn't control, which is the fact that they were approaching 90 and they were mortal. And they began to focus on what they could control, which were the joys and blessings of this 63-year-old marriage they had. So she lived another 4 months, never saw a doctor. Occasionally someone would call in a change in the medication, and she died at home of congestive heart failure. And it was very sad. I was there, but so was my dad. She was in bed with him. We were all there. It was what she wanted. It was very sad and very beautiful, I guess it was. So here's my point. Medicare will pay for all those lab tests, no questions asked. It would have paid to put her in the hospital for atrial fibrillation, renal failure, congestive heart failure, all during that 4-month period, and the ambulance to take her there. It won't pay a physician or a nurse to spend an hour with an aging patient explaining the difference between care and cure and helping them navigate this bewildering array of things we can do to you but not necessarily for you. A conversation that should be done when you're 50, not just when you're 95. And it won't pay $18 an hour for a non-hospice caregiver to actually let her stay in her own home. Hospice is great, but she needed someone to do the laundry, take her to the bathroom, do the grocery shopping. So my point is that we've created a system that I don't think is necessarily synchronous with our culture. Most people would rather die at home with their family and friends rather than in an acute care hospital. But we have a system that essentially creates a set of incentives that drives people into the hospital. And I'm convinced that if we could describe the parameters of a new system and what we want end-of-life care to be about, it's about honoring the individual. And if we created non-acute care venues and ways to fund them, if we paid for compassion and care and support, a lot of people would choose that. And I don't think you'd ever have to tell somebody they couldn't go to the hospital. A lot of people would choose something else. And that's a conversation that has to start at the community. The recent furor about death panels resulted from an amendment put in by Earl Blumenauer, who's a congressman from Oregon, that essentially tried to provide some funding for physicians to have exactly that conversation. And apparently you can't have that, you can't talk about those things in the United States Congress anymore. But we're all going to die. And we need to have that conversation and talk about it and get it on the table, and that has to start right here at the community. You had another question I probably didn't put. The immigration one, I'm just going to touch on this real quick because this comes up a lot. I just think that the immigration issue, the issue of undocumented aliens, is not a healthcare issue. It's an issue that has to do with federal immigration policy. There are economics involved, particularly in the interface between the job market, let's say in Southern California, and wages in Mexico and in California, and other border states. It's a real issue, it's an important issue, and it's manifested in the healthcare system because a lot of those folks will seek care through the emergency department. But it seems to me that we need to start out by saying, let's fix our healthcare system so that it provides effective, efficient, affordable care for a human being, whether they have a green card or not, whether they're a Republican or a Democrat or an independent. Let's get a system that takes care of a human being. Then let's say, okay, now how do we fix the immigration issue? I think they're two separate things. And if you mix them up, it really does muddy the water. I'll finally say that in California, for example, in Southern Oregon, where we do have a lot of migrant workers in our agricultural industry, and I'm sure there are a fair number of undocumented aliens among them, when they come into the emergency room, we don't check to see if they're a green card, if they've had a motorcycle accident. We don't stop and say, well, we're going to make sure you're documented or else we're just going to let you die. I don't think we're going to do that in this country. So if they're here, it makes a lot more sense to give them access to some kind of primary care rather than see them later in the emergency room. Which doesn't mean that we should condone them, but I just think that it's not really a medical issue. It's a different issue, and I think we're mixing apples and oranges if we go there.
The question I'd like to put forth is actually to the Elmhurst College administration, and that is, I'm just wondering why there was not an alternative speaker with, with the alternative view presented by the college today. I mean, I don't understand why there's not a balance here of another speaker with, the cons of having a government-run healthcare. That's what I'd like to know to the college.
Just for the record, I didn't advocate a government-run system. I advocated changing the delivery system regardless of how we pay for it. So if that's what you heard, I think you missed the point.
Well, I'm reading between the lines. That's what a lot of Democrats in Congress are eventually working towards. I mean, you're going to do it incrementally, but I mean that's what the end of the line, goal seems to be. So, but my main concern is not so much that you have an opposing point of view than myself. I'm clearly against, that. But I wish the college would present, another speaker, like a panel, somebody with, a different point of view on it. That's all. Thank you.
Well, I think you stated the case for yourself, and that is that we have a noted national speaker today coming in to address us. We're delighted that he's here. He has spent a lifetime in healthcare and healthcare reform. This is a conversational piece that we're engaged in with the identification of issues that we need to reform, revitalize, and make a part of our future. And that is the purpose of the discussion, not necessarily, and the governor does not come here advocating that you have to accept everything he says, but that's the purpose of academic freedom. Now, on the other side of the coin, you're more than welcome to state your viewpoint, as we would encourage you to do, and there will be continued discussion on health care reform at many fronts. Thank you.
Governor, my name is Pete DeCiani, I'm actually the mayor of Elmhurst.
Yes.
And I'm
Let's say hello to the mayor.
I also was involved in a healthcare bill last year called Brianna's Law, which is named after my daughter, who has an ASD disorder. Yesterday we saw the national news that autism is now increased from 1 in 150 to 1 in 91. It was on national news and for sure all the networks. I dealt with our situation through an insurance mandate. I kind of took it in a similar venue in my presentation to the insurance industry with let's spend $1 now, because if we invest in the wellness of our children when they're young, we're going to save $9 or $10 later, because at that time it's the type of care they're going to need is disastrous, and it's going to be very expensive, and most of it's going to be burdened on government. So when I sat down with the insurance industry, I sold it that way, very similar to how you're selling it to the audience. But I did it through an insurance mandate versus government care, because we also want to make sure that we get the best of the best treatment, and we have the opportunity to pick the providers we go to as well too. So I think there's a happy medium, and I like, in a lot of ways, your philosophy with nipping the problem early with the wellness program. I wonder if we could actually approach it through a wellness mandate. Would that be a possibility? Would that go over well with industry? What are your thoughts on that?
Well, I guess it's. I guess the question is, what it is that you're mandating. If you passed a law that says everyone has to be healthy, it would be pretty hard to enforce. I think that the places that have actually had experience changing, because health is to a large extent a behavioral issue. I mean, you don't have to smoke, you don't have to drink, you can exercise, you can adjust your diet. But as I said, there are places in America where the inner city has been sort of abandoned, and there's people who live there who don't have access to healthy foods, who don't have the option to make those kinds of decisions. So the places that have actually changed behavior have done it basically in a defined population, such as a workforce, an employer. And it's done through a combination of education and economic incentives, creating incentives, as I mentioned, value-based cost sharing. So the idea is it's a minority of the population that's driving most of the healthcare costs. And if you can figure out a way to not just mandate it, but to have the tools necessary for people to comply with the mandate, I think that's really what the challenge is. And again, education and economic incentives have been a fairly effective combination, both in public sector efforts and in private sector efforts. There's a hospital in Wisconsin, in Green Bay, called Mellon Hospital. You might want to Google that has done an excellent job of this with its own employees, essentially mandating wellness within its own employees by creating a structure that allowed them to take advantage of the opportunity.
There's a question here. I'm Jim Doyle, Chief Financial Officer of the health system, and so I deal on a day-to-day basis with spending and where the money actually goes. This is something, I guess, a reflection of where is there hope. As you mentioned, there's numerous examples across the country of situations that have seemed to get control of things. And the paradigm that you speak of is certainly intellectually attractive, but when I think about the practicalities of, it's one thing to speak to an academic audience or a group of healthcare people that kind of get it or have been in it long enough to understand parts of it, but the difficulty of getting this level of understanding across to basically the political body that maybe controls enough of the spending. And I guess the common question in all of this is, how do you get enough of this to seep in and make a change such that it happens before the Chinese shut off the debt?
Well, that's a very good question. And, we are not a society that is prone to long-term thinking in terms of our policies. I mean, I do think that there was a lot of long-term thinking when it went into creation of the interstate highway system under President Eisenhower. There was a lot of long-term thinking that went into creating our system of higher education. But we become sort of a quick turnaround, 24-hour news cycle, fast food society that doesn't want to wait for anything. We really sure don't want to spend something now to get something in the future. And that's really what the national debt is. It's us basically spending our kids' money to support what we're doing today. So I think that as the fiscal crisis, which I believe is going to come, I believe that we're on a trajectory to default on the national debt. It doesn't take a third-grade math student to sort of calculate this out. And I think pressure's going to mount as we get closer to that, but I think the best public policy is not made in crisis. So my hope is that at the state and regional level, there will be innovative demonstrations or pilot projects that begin to provide examples for other people. Bellin Hospital is a very good example. You'd be amazed how many hospital systems do not have a wellness program for their own employees. You would be astounded. Swedish Hospital in Seattle originally had no wellness program for its employees, no integrated care options for them to exercise. So there's a lot that can be done there. There's a place in Central Oregon I mentioned earlier, 3 counties, that has a fairly defined geographic area where the hospital and the physicians and the employers and the members of the community have set out trying to design what an optimal healthcare system would look like in Central Oregon. And their belief is that they can get everyone to agree on what that looks like, then they're going to go out and seek the waivers from Medicare, Medicaid, and changes in state insurance regulations to allow them to actually move in that direction. So I think you're going to be seeing that, and my belief is that the pressure to fix the healthcare problem is going to increase politically, no matter what comes out of Congress this go-around. It'll increase for political reasons right before next year's midterm elections, and it'll increase pretty dramatically ahead of the 2012 presidential election. And in that window, I think Congress is going to be very interested, and the administration, in supporting big local and regional demonstration projects that they can point to and say, yeah, that's what we need to do. And so I think there is an opportunity for that kind of creativity. And I do know that there is a lot of creativity in this community. And I think, as I said earlier, it needs to start with community hospitals, their medical staffs, and their boards of trustees, because those boards of trustees are usually representative of the larger community. So you do have the mix that you need to move forward.
Doctor?
Yes, sir.
It's been a real pleasure listening to somebody who can articulate a very difficult subject and present some solutions to it as you see it. But I have to ask you one question concerning not as you define the healthcare issue, but as you also define this precipice that the raft is going over. And can't we get our leaders to recognize that in 2010, the circumstances in the medical profession is different and substantially better than what it was in the 1960s when Medicare came into being and those people, that wonderful generation, saw fit to enact why can't we recognize that entrance to that Medicare group has to change and reflect the advantages and all of the programs that the medical profession has given to us as U.S. citizens?
Well, I think you put your finger on the question. I'm not sure I can answer it, but Medicare is a wonderful program. I mean, millions and millions of people have benefited because of Medicare, and I think we're better off as a nation because we set about explicitly to make sure that people, when they aged, did not go without needed medical care. What's changed, of course, is the fact that people are living 20, 25 years beyond the age of 65, and medical inflation is much higher now, and most of them consuming far more resources than they paid in during their lifetimes. Which isn't a criticism, it's just a demographic fact. And so we're not really talking about getting rid of Medicare, we're talking about, making it into a program that's really focused on health rather than just after the fact treatment of medical complications of diabetes, say. And the problem in Washington, D.C. is, I've talked about this earlier today, I just think it's really badly broken. And I think what's going on today is not a thoughtful discussion about those kinds of questions. It's both parties trying to position themselves for the acquisition of partisan majorities, rather than saying, okay, we're in the majority, let's use that to actually start to fix the problem, or even better still, let's work with each other. And I don't know how to get beyond that except moving the debate out of the beltway to the state, regional, and particularly local level, where I think there still is more civility and more ability to work with each other, not as partisans, but as people who are bound together by a common future.
Thus, you don't see any opportunity to up that 65 years to 70 or 75. Maybe in 20 years, it'll be 80.
Yeah, I think that's a conversation that definitely should be on the table. I just don't see it getting on the table anytime soon in Washington, D.C. Regretfully.
One more question here.
My question has two parts. What if...
Well, you're sneaking two questions in.
Two more questions.
What, if anything, do private insurance companies now contribute to the social good? And what do you think of single payer?
Well, I think a single payer is another way to pay for something. And if you had a single payer, Medicare is basically a single payer system. I mean, all the money comes from the public sector. So a single payer system, without changing the fundamental delivery organization of the care you're delivering, doesn't solve the larger cost question. It will, however, reduce some administrative costs by eliminating private commercial insurance. I think there's definitely a role for private commercial insurance. And I think what I'm describing is that I do believe that ultimately we need to come to terms with the fact that people in this country do have to have access to some level of medical services that affect their health. And we do that now through the emergency room. I've never heard anyone say that we should adopt a law that says if you don't have health insurance coverage or can't pay, we should let you die in the ambulance ramp. I've never heard anybody of either party say that we should do a wallet biopsy, and if you're Blue Cross negative, you get to die. Right? So de facto, we have universal access. It's just a pretty silly way to do it. Now, in that tier, that basic level of care, I don't think there is room for fee-for-service medicine, which has all the wrong incentives for creating a population or a health-based system, or for the kind of underwriting we see with private commercial insurance. However, there's going to be a robust secondary insurance market for people who want to buy additional services with their own after-tax dollars. And it seems to me that is where the role of private commercial insurance should be, and that's where the role of good old fee-for-service medicine should be. But I do think that there's a certain level of care that people have to have in order to be healthy. And if you're not healthy, you can't work, you can't exercise any of the opportunities that go along with living in this country.
Please join me in thanking Dr.